seconds.
3, 2, 1.
Yep, 3, 2, 1, go.
Greetings, everyone. Thank you for joining our webinar presentation titled Patient-Centered Research on Traumatic Brain Injury. I'm Dr. Vani Rao, project leader and faculty at Johns Hopkins University. My co-presenters and project co-leaders will be Dr. Louise Bunever, also faculty at Johns Hopkins, and Mr. Brian Pugh, executive director of the Brain Injury Association of Maryland. Today, we are going to be sharing the results of a project that we just completed. The project was jointly conducted by the Brain Injury Association of Maryland and the Department of Psychiatry, Johns Hopkins University. Again, the project is titled Patient-Centered Research on TBI or Traumatic Brain Injury Psychiatric Problems. The sponsor was Patient-Centered Outcomes Research Institute, also known as PCORI. The award was the Engagement Award number 7136-JHU. Here is an overview of our presentation. As this is a PCORI Engagement Award, I will first provide a brief overview on PCORI engagement and our project background. Dr. Louise Bunever and Mr. Brian Pugh will later discuss the project results. Let's start off with an overview on PCORI engagement. The mission of PCORI is to produce and promote high integrity, evidence-based information that comes from research guided by patients, caregivers, and the broader health community. The overarching goal is to help people make informed healthcare decisions and improve healthcare delivery and outcomes. Now, what is engagement? Engagement means the meaningful involvement of all stakeholders. This includes patients, caregivers, clinicians, and anyone else who have interest or concern in the disease or illness. Engagement is throughout the research process and includes planning the study, conducting the study, and disseminating study results. Now, why does engagement matter? There are 3 good reasons. 1, it leads to researchers studying questions pertinent to patients and stakeholders. 2, it leads to stakeholders participating in research projects as either partners, collaborators, or even team leaders. And 3, it leads to projects that patients and stakeholders can use to make informed decisions about healthcare. So with this brief background on PCORI engagement, let's move on to the project background. Now, neuropsychiatric problems after traumatic brain injury are common and associated with a host of negative outcomes. It's known that at least about 40% of individuals who incur a TBI experience 2 or more psychiatric problems after their brain injury. It's also known that about 40% have at least one unmet need for cognitive, emotional, or job services 1 year post-injury. And sadly, the entire spectrum of TBI severity, including mild, is associated with increased TBI psychiatric morbidity. Common neuropsychiatric problems include emotional problems such as depression or anxiety, cognitive problems such as memory problems or concentration problems, behavioral problems such as impulsivity or disinhibition, and neurological problems such as headache or seizures. An informal survey conducted jointly by the Brain Injury Association of Maryland and clinician researchers in the Department of Psychiatry at Johns Hopkins in 2016 revealed major barriers of recovery after TBI to be lack of awareness on neuropsychiatric problems and resources after TBI, and inadequate research on diagnosis and management of neuropsychiatric problems after TBI. Similarly, In a study that was also conducted by Albrecht et al. On TBI recovery, major barriers included poor insurance coverage for treatment of mental health symptoms following TBI, transportation difficulties, including difficulty getting to clinics or neuropsychiatric clinics for management of symptoms, and difficulty accessing professional help or services for their neuropsychiatric problems. So putting it all together, there is good evidence that many people with TBI suffer silently. Therefore, there's a need for TBI researchers to collaborate with other stakeholders and create a TBI patient-centered outcomes research network with the ultimate goal to better understand needs and provide appropriate services. So it is with this background that we decided to conduct the study. The specific aims of the project were to facilitate TBI stakeholder group discussions about facilitators and barriers to management of neuropsychiatric problems after TBI, best strategies for continued engagement of a TBI PCORI network, pertinent TBI neuropsychiatric research questions or topics, and needed policy changes related to neuropsychiatric problems after TBI. Put in another way, the project aims include: 1, to determine factors associated with success and barriers of TBI neuropsychiatric care; 2, determine strategies to maintain a TBI patient-centered outcomes research network; 3, identify pertinent TBI neuropsychiatric research topics; and 4, enumerate important policy changes necessary for improved TBI neuropsychiatric care. As with any other project, we had to obtain Johns Hopkins Institutional Review Board approval to conduct this project, which we did, and here is the application number. All right, we had some simple inclusion-exclusion criteria to establish the TBI PCORI network. Inclusion criteria included: for persons with TBI, they should have been diagnosed by a healthcare professional to have had a TBI. The time duration or the window period since their TBI should have been greater than 3 months, but less than 5 years. In addition, they should have experienced neuropsychiatric symptoms following their TBI. For caregivers, they should have been involved in the care or in caring for a person or persons with TBI for at least 3 months or more. For clinic coordinators and clinicians, they should have been involved in the care of 10 or more people with TBI. For all, they should be willing to come to Johns Hopkins Bayview to participate in focus group lasting about 3 hours. They should have also been able to come to Johns Hopkins Bayview and attend a research education class, and they should be able to speak and understand English. For the exclusion criteria, we did not take children, nor did we include people with other types of brain injury. We strictly wanted traumatic brain injury for this project. In addition, we also wanted people who are able to provide informed consent. And those people who are either medically or psychiatrically unstable were not included in the project. So participants were recruited using a Hopkins IRB approved flyer. The flyers were posted on the websites of the Brain Injury Association of Maryland and other TBI clinics. Flyers were also distributed to other participants, and flyers were distributed using social media. Individuals interested in participation were at first telephone screened, and then we had in-person screening. And those who met the inclusion-exclusion criteria were asked to provide written informed consent. So this TBI PCORI network included TBI stakeholders, about 30 of them, a project leader and 3 co-leaders, a project coordinator, 5 advisory board members, 2 consultants, and the collaborators were the Brain Injury Association of Maryland and the Brain Injury Association of America. So there were 2 phases of engagement. The first was a research education class, and the second was focus groups. The research education class included a day-long class conducted by an expert on community mental health research. We had 2 seminars. The first one was on basics of general research, and the second one was specifically on PCORI research. The 2 seminars were followed by 2 interactive workshops, and the workshops also focused on the above 2 topics. We conducted a total of 5 focus groups. Each group had 6 participants except one, which had 5, as one person was unable to join. Each group lasted for 3 hours. All focus group discussions were audio recorded. In addition, at the end of the focus group, we also conducted an in-depth interview with a volunteer from each of the group. A focus group guide was created on the 4 domains of inquiry. Again, the 4 domains included: 1, success and barriers to TBI neuropsychiatric care; 2, strategies to maintain PCORI network; 3, pertinent TBI neuropsychiatric research topics; and 4, needed healthcare policy changes for neuropsychiatric care. The recorded interviews were transcribed verbatim. The project leader and a co-leader summarized and coded the transcripts manually and also using a software. Codes were generated based on themes that emerged. And then finally, a consensus conference was held where the 4 project leaders to discuss and finalize the results. So moving on to results, 70 participants were screened. Of them, 30 who met the inclusion-exclusion criteria were subsequently enrolled in the project. The 2 common reasons for exclusion were people who did not have a traumatic brain injury but had other types of brain injury, and if the TBI was incurred greater than or longer than 5 years. A total of 29 participants participated in the focus group. As I mentioned earlier, one of them was unable to do. We had a diverse group of participants. They included persons with TBI, caregivers, physicians, non-physician clinicians, and TBI educator and coordinator. So let's move on to the results, and I'll have first Brian discuss the results of the first 2 domains, and then we'll have Luis discuss the results of the 3rd and 4th domain. So Brian, take it over.
Thanks, Vani. The first domain, as Vani mentioned, was the barriers and facilitators for neuropsychiatric care after TBI. So we were really trying to find out specifically what were the things that were preventing neuropsychiatric care after TBI, and then also what were the things that were really helpful in doing that. And so what we were able to find through our discussions was that one of the main reasons was stigma. And the stigma is very, very prevalent within the TBI community. And then even with the mental health disorder being involved, it created even more stigma around it. And within that, there was also inadequate insurance coverage. The difference between psychiatric disorders and mental health disorders, and were not being fully funded at the insurance levels. Some of the things that were resolved with the rehab did not take into account cognitive and behavioral issues. So whereas maybe somebody had recovered to be able to walk, maybe regained enough balance to move around, maybe regained enough function to, go through normal ADLs, but the cognitive behavioral stuff was still at large. And then adding into that was the challenge of an additional behavioral or mental health disorder. Insurance coverage was really, really a problem. Some of the things that helped in that area were education on neuropsychiatric problems and acute trauma, so that those individuals in those areas that were able to get the neuropsychiatric issues addressed or have some education on that was very important to them. So rather than being labeled bad or crazy, the educated people were able to then, at the time of discharge, tell them about having a comprehension of the do's and don'ts. We were able to establish valid caregiver plans, and those were the kinds of things that the families and the caregivers and the professionals were looking for. Help with caregiver burden was also something that was really, really helpful. So again, if I was able to get a valid discharge plan, I was able to get set up with resources in the community so that when I went home, I wasn't just sort of left on my own. Building around 360-degree support services around the individuals that were coming home that would address both behavioral and mental health disorders, in addition to the stuff that the families were having to deal with and just the brain injury issues, became very, very helpful to them. And those facilities that were able to do that for the caregivers were the ones that got the highest marks. So how do we go about breaking down those? The participants urged the healthcare providers who are knowledgeable about TBI and about neuropsychiatric symptoms to routinely educate family members about the factors contributing to neuropsychiatric symptoms after TBI, as well as the dangers. So some of the dangers were mentioned were isolation and detachment, and those labels of crazy and impaired. Those are the things that are going to be harmful over time. And very isolating. It was a really, really bad concern that the friends that people had before this incident happened were there sort of in the initial phases, but then sort of drifted apart. And it became a very isolating thing for not only the individual with the brain injury, but also the family members, as people became more challenged to know how to respond. And also respecting them as individuals and helping connect them socially so that, you know, the patient's not the patient is a person. You know, it's my husband, it's my wife, it's my daughter. Don't think of them as just somebody in your file or somebody to be dealt with. I mean, this is somebody that we need to introduce as a person and make those connections. In terms of improvement of care, the participants recommended educating insurers on the nature and chronicity of the neuropsychiatric symptoms after TBI. This is not a broken arm that you can put a cast on and 6 weeks later you take the cast off, 2 weeks of rehab, and you go back on your way. These are long-term chronic issues that need to be dealt with over time, and they change over time. This is not something that a drop-down menu can cover. And so therefore they recommended providing incentives such as special reimbursements and loan forgiveness for clinicians involved in the care of persons with these symptoms, so that more clinicians could get into the field and then also be able to medically back reasons to continue this insurance and to continue these, the ability of the community to address these issues and the ability of the medical profession to address the issues as they arise. In addition, we talked about reinforcing those issues. And so managing neuropsychiatric problems in an acute trauma period. So address the problematic behaviors early on. Recognize that there are phases in the evolution of the rehab of somebody with a brain injury. In addition, it's complicated when somebody has a mental health disorder or has an emerging mental health disorder as they come out of their TBI. There needs to be more education of family members about the types of stages and ways in which the loved one is going to be coming into and emerging from the brain injury and things to be expected. While every brain is different and every brain injury is different and every brain injury recovery is different, there are some significant milestones that can be sort of marked and benchmarked, and those need to be described and told to the family members at the time. And then again, to reinforce the idea of a comprehensive discharge plan that don't just set me loose, don't have me sign the papers and walk out and drive home. As we start making this discharge plan, we need to start thinking about setting up, who's going to be watching this person, who's going to be training this person, what are the different therapies that are going to be necessary, and how can we get in touch with those, and even medications, who's going to be helping us with that and manage those kinds of things. And then with the caregiver burden, continuing education. This is something that the participants really came forward with, and that the healthcare providers that were in the room also really agreed with, that this is a changing and evolving issue. This isn't a changing and evolving problem. And so the issues that happen 30 days out are going to be different than 90 days out, are going to be different than a year out. And there needs to be an ongoing opportunity for the caregivers to get educated about those different things and to have a resource that they can go back to as they start finding new and different emerging issues. And then also to have a do's and don'ts caregiver plan. These are ways that you can really facilitate an improvement. So let's say it's a behavioral issue or a cognitive behavioral issue. This is the way it might manifest, and these are some strategies you might want to try to modify it and try to bring it around or try. And if those don't work, to have at least an opportunity for someone to call or somewhere to participate in a group or an educational setting that they can sort of throw these ideas out and try to get some ideas to help them. So the second domain was maintaining the PCORI network. So one of the things that we did going into the study was we wanted to not just make this be a one-off. We wanted to say what was going to happen, what can help create a core group that we can continue to come back to and find out how to better serve this community with person-centered outcomes. And so we don't want this to just be a project that Ivani and Lewis and I and the variety of other providers that helped us on this project to sort of take a look at it, create some things, and then move on. We want to be able to sort of maintain that group. And so we posed these questions to the group to try and make sure that this was not going to be something that would ultimately disappear. So we wanted to define, how best to do this. And so in summary, what we ultimately came away with was having a defined project, a project goal, a process, outcome, so that we can say, we need you to help us address this issue. And the reason we want this issue is because we've talked to all of you, and this continues to be an issue. It might be an insurance issue. It might be a treatment issue. It might be a paperwork issue. But this is something that we want to sort of put back in your lap and give us your ideas and your input on how best to address this issue. Without a defined project or defined goal, then it becomes more like sort of a round robin discussion, more of a support group, which is, very valuable and necessary for the task that it provides. But the reality is it wasn't exactly what we were looking for in terms of how can we make a difference to this core community. So a defined project was important. Conduct regular meetings. This is always the challenge when you're trying to sort of prolong something or keep something going. How best to do that. And the way that we were talking back and forth throughout the variety of focus groups, maybe longer quarterly meetings with shorter bi-monthly check-ins. So it would be something where we could present something quarterly, give individuals a reason to come back, get educated on a particular topic or educated on a particular idea, and then have shorter bi-monthly check-ins, sort of like this, sort of a Zoom room that people could call in and say, how are things going? What's the latest going on? Just in order to help people stay connected. Because that we wanted to be a primary outcome of this research project. Make participation convenient, combine in-person with virtual meetings. And so they urged us to try very hard to use technology as best we could, to try and maximize the number of people that participate, minimize the inconvenience. And they posed a variety of different ideas, maybe having centrally located meetings in certain areas, maybe using a Zoom room or a Skype technology for those people that could do it, but then also have a telephone call-in for those individuals that weren't as technologically inclined or had challenges with the technology, but to make it convenient so that people could do more. The final thing was thinking outside the box. They really wanted these workshops and seminars and guest speakers to sort of be quasi-social. Don't make it, strictly about a policy and procedure or problem, but also add an idea, sort of enrich the participation and make it be interesting for the people. So like we talked about guest speakers, bring in subject matter experts and have them do presentations on the latest advances on a particular topic, workshops or seminars, so that the groups could continue to be educated on a particular aspect of the evolving nature of brain injury research and mental health research and the comorbidity of both, to try and make sure that there's an opportunity for members to interact so that they could be, there might not always strictly be we have a workshop or a seminar. We'd just like to have a gathering, and sort of maybe bring in the public as well, and maybe have it be an outreach type activity where the community consider having in public places such as a church or at a school or in a park, and invite the public and invite other community leaders, so that they also can learn and be exposed to this sort of the issues that are being addressed here. So those are the first two domains, and I'll turn it over to Luis.
Thank you, Brian. So I'm going to be discussing domains 3 and domains 4. Domain number 3 pertain to pertinent TBI neuropsychiatric research topics. So one of the things that we did in the groups was solicit from our TBI patients and the relevant stakeholders topics that they believe are important and would be important for us to study. TBI and aging was identified as an area of importance. Some of the things that participants were, our focus group participants were interested in, some of the issues they raised included, is TBI a risk factor for dementia? What are the differences in the neuropsychiatric profile of normal aging as compared to TBI and as compared to aging observed in patients with dementia? Another thing that was raised was, how does TBI interact or interfere with the typical aging process? Does TBI shorten the lifespan? And if so, is there a way to mitigate the factors associated with it? This was an area that was of deep concern for people, was learning more about how sustaining a brain injury can increase their risk for a neurodegenerative disease, kind of such as Alzheimer's or dementia, and also wanting to know whether TBI can affect mortality and how that would affect the aging process. TBI and positive outcomes. So what factors are associated with good outcomes after TBI? So what we did in the groups was discuss the different things that are important in helping people who have had a TBI make a successful rehabilitation recuperation. So the first thing that was discussed is having a navigator, or in other words, a person who helps guide the person with the TBI and the TBI caregiver through the healthcare system effective. So we talked about the importance of having a navigator type of individual shepherd the TBI patient and TBI caregiver through the healthcare system and how that might be beneficial. Number 2, how does telemedicine and or a smart app, having a smart app intervention compared to traditional rehab therapies in influencing outcomes? So number 2 pertains to using technology and technological advances in the service of TBI rehab and treatment. TBI patients and stakeholders are very interested in starting to incorporate telemedicine and technology in treatment. Number 3, what is the role of insurance in influencing outcomes? So there were concerns about whether all services, therapies, treatments are covered by insurance. And there were specifically concerns about what happens when your insurance company doesn't cover or insure all of the different therapies. Does that reduce the likelihood of returning to functioning and to independence? Number 4, what is the role of culture, socialization, and human interaction in influencing outcomes? So many times, people that have sustained a TBI are self-conscious about different labels and how their personalities and might influence or impact the way in which they relate with other people. And being self-conscious about these and catastrophizing about these types of things, how they will be received by others, either in social situations, family situations, or work outcomes or work environments, how worrying about these types of things can influence outcomes, as well as how educating others about a brain injury can facilitate having others be supportive of the person with a TBI, how that can influence outcomes in a positive way. Number 5 was, what are the effectiveness of alternative therapies? So complementary and alternative therapies such as yoga, exercise, diet, dietary supplements, neurofeedback, homeopathy, or mindfulness. So there are many different complementary and alternative medicines that have not been well studied or well characterized. And many of our TBI patients and TBI stakeholders are very interested in learning more about this. TBI and addiction. So this was a topic that was also of great interest to our focus group participants. How are TBI and addiction connected? What are the neurological associations and clinical demographic factors associated with decline in substance use after TBI? Do rates of alcohol and substance abuse increase or decrease after TBI? Does TBI lead to addictive behavior? So in eating behavior patterns, such as overeating or binging. TBI and neuropsychiatric problems. So regarding this topic, people were interested in discussing what type of psychiatric problems are risk factors for TBI. So for example, attention deficit hyperactivity disorder, ODD. There are different psychiatric illnesses that can raise a person's risk for sustaining a traumatic brain injury. And many of our participants were interested in learning more about this topic. Another issue that arose was what tools should be used to screen for TBI in children with ADD and ADHD, and how often should it be done? And then the other issue was, what are the genetic factors that might predispose people to develop TBI and psychiatric problems after a TBI? So two different things. So is there a genetic predisposition that can elevate a person's risk for sustaining or suffering a TBI? And then what are the psychiatric problems after a TBI? Additional research questions were, TBI and sexuality was a very big topic that people were interested in and felt was not adequately addressed, or that is not adequately addressed at this point in time. People are interested in learning, how does TBI affect sexual functioning and sexuality? What are the non-harmful and safe methods to express sexuality after traumatic brain injury? Number 2, TBI and its impact on caregivers. So the focus of TBI research is largely on patients who have sustained a traumatic brain injury. And the sentiment was that the stakeholders and TBI patients and caregivers would also like to see more research on how TBI, caring for someone who has a TBI, impacts caregivers. What kind of support strategies would prevent caregiver burnout, for example? And are there overlapping personality characteristics of caregivers who help optimize recovery? Number 3, TBI and domestic violence. How common is TBI in persons with domestic violence and brain injury? So given the stigma around being a victim, what is the best form of TBI assessment in victims of domestic violence? Number 4, TBI and neuroplasticity. So in TBI and neuroplasticity, there is an interest in what are the factors associated with neuroplasticity after a TBI. Are there biomarkers that could potentially assist with the problems of medications? So people are interested in learning, are there things or factors that can facilitate or impede the creation of new neural networks after a brain injury? Number 5, TBI and telemedicine. What is the effectiveness of telemedicine in managing TBI mental health symptoms? So the issue was brought up that many times people who have sustained a TBI do not live in a large metropolitan area and therefore do not have access to state-of-the-science treatment. However, telemedicine is one treatment modality that can address this gap in treatment, this disparity. Number 6, TBI and personality. How does TBI impact an individual's personality? How can these changes in personality be managed after a TBI? Domain number 4. This domain focused on needed policy changes. Needed TBI mental health policy changes. So one of the things that was discussed in our groups was the need to implement 360-degree mental health policy changes. So, for example, mental health education of patients, caregivers, physicians, and non-physicians, clinic coordinators, and legislators. That there's not enough education about brain injury among people who have the ability to influence policy and procedures. Improve telehealth services. Patients and stakeholders are interested in having more monies available to fund research on TBI telehealth models and also on adequately reimbursing individuals providing TBI telehealth care. Create federally funded TBI programs useful for homeless and indigent populations. Number 4, training and compensation for TBI navigators. So not only having someone who is trained and knowledgeable on helping to shepherd TBI patients and their caregivers through the confusing and complex healthcare system, but setting up training programs with competitive salaries to attract people to these types of positions. Incentives for clinicians involved in the care of people with TBI and neuropsychiatric problems. So this pertains to creating different incentives to motivate people to go into the care of patients with TBI and different neuropsychiatric problems.
Okay, I'm going to take it from here. So conclusion. So the goal of this project was to highlight the importance of patient-centeredness in clinical care and research in TBI neuropsychiatry. We assembled a network of passionate stakeholders with personal and professional interest in manifesting this goal. Through focus groups and individual conversations and discussions, we elicited ideas, suggestions, and recommendations on 4 different topics. They were facilitators and barriers of TBI neuropsychiatric care, strategies to maintain a brain injury PCORI group, pertinent research topics in TBI neuropsychiatry, and needed healthcare policy changes related to TBI neuropsychiatry. Finally, we've used this project as a platform to engage TBI stakeholders in discussions on a variety of topics on TBI neuropsychiatry. We hope to use these results from the study to develop other projects meaningful to our participants and the larger community. We also hope to continue to engage our patients as partners or collaborators and leaders in future projects. We'd like to thank PCORI for giving us an opportunity to conduct this study. We'd like to thank our participants, our advisory board members, and consultants for their continued support. And lastly, we'd like to thank you, audience, for your attention.